Good morning, good afternoon, good evening, everyone. It's Tuesday. It's Neurology Morning Report. Thank you to everyone for joining. You know the routine. We'll need someone to present a case if they have one, and two people to discuss that case piece by piece. Do we have any volunteers for any of these roles today? Did anyone bring a case they were hoping to present today? All right. All right. And anyone like to discuss a case? If no one has a case, we always have some backup cases. So we'll just need two people to discuss, ideally one identifying as a woman and one identifying as a man. Ravi Patel, wonderful. Anyone else like to discuss with Ravi? Ideally someone identifying as a woman. Promise, that would be great. She's offering if someone else wants to discuss, and she's discussed before, but it's been such a long time, Promise, that doesn't count. It's okay. Anyone else was hoping to discuss today? All right, I think that's a new world record. By 9:03, we have a case and two discussants. So we'll have all the more time to talk about our beloved topic of neurology. Great. So Gabby, Promise, Ravi, would you like to introduce yourselves to everyone?
Yes, my name is Ravi. I'm a fourth-year medical student calling from India.
Great. And where in India are you calling from?
I'm calling from New Delhi.
From New Delhi. Wonderful. Great. Thanks for joining us. And Promise?
Hi, everyone. My name is Promise, and I'm a second-year medical student in Chicago.
Fantastic. And Gabby, everyone knows you, but just in case, I know we have some people joining us for the first time.
Yeah, of course. So my name is Gabriela. I am speaking from Brazil, and I am a neurologist here. I hope you like today's case.
Fantastic. All right. And Kirtan and Shema are going to be helping us describing and teaching points. So let's go ahead. Gabriela, would you like to tell us the chief concern in as few words as possible, as is our custom?
Yeah, of course. So today's chief concern is vertigo.
Vertigo, a one-word chief concern and a very good one at that. Okay, Promise, what comes to mind when you hear vertigo?
Honestly, the first thing I think is is it a cranial nerve damage? Also, I think I remember you taught me that it's really important when it comes to neuro chief complaint to think about the time course and the localization. So I definitely want to know when this happened. And well, for vertigo, you wouldn't really think about the localization, but I think just hearing more about like how it happened, and then if there's any trigger, and then also trying to see if there are any other associated symptoms. But I think right now I'm really thinking about the cranial nerve at this stage.
Okay, great. And which cranial nerve are you thinking of?
8.
Cranial nerve 8, yeah. So that's one part of the potential localization. We'll talk about that. Could it be a problem with cranial nerve 8? So as you said, our framework always in these morning reports, as in real life, when we discuss a neurology case, right, is to think about the localization and the time course. So we'll have to think a little bit about what system is impaired if the patient is experiencing vertigo, and cranial nerve 8 is part of that system. And then the time course, as you said, did this happen suddenly, or has it been going on for a long time? Is it provoked by anything, or does it happen spontaneously? We'll get into some details of that framework in a moment, because this is one of my favorite topics. So I'm excited to talk about it, but I want to hear your perspectives first. Ravi, what's coming to mind for you when you hear vertigo?
Yeah, what's coming to my mind when I hear vertigo, the definition of vertigo is like spinning sensation, or especially when they turn their head, when they sway their body, the motion of the environment changes. So that's the patient usually describe. So that means that either the head positional, that what comes to my mind is a benign BPPV, benign positional, okay, BPPV comes to my mind, in addition with the ear, the ear dysfunction, the salt cells in the ear, and Meniere's disease comes to my mind, and or schwannoma, okay, tumor in the brain, or in addition with the cerebellar pathologies. Thank you.
Yeah, great thoughts, Ravi. So you've taken us a little more along the pathway of localization here. So a couple of great points. First, let's define what vertigo is, right? And you said a spinning sensation. That's part of the definition. I think the classic definition is an illusory sense of motion, meaning the feeling that something's moving when it's not moving. And some patients describe that as the room spinning, as you said. Some patients say it feels like they're on a boat. Some patients say it feels like they are spinning, but illusory sense of motion, I think, is that technical definition. And so if there's a problem with our sensation of motion, I'm sure you've all had the experience where either you're sitting in a car and a train and the other car or train starts to move in one direction and you feel like you're moving, but you're not moving. And so you have that feeling a little bit nauseous, right? Of your brain thinks you're moving and you're not. Or you go to the IMAX theater and watch some thing where the drone is flying down through the Grand Canyon and you get a little nauseous because your brain is getting the signal that you're moving, but you're not. So illusory sense of motion. Now, Gabby said vertigo and not dizziness, right? But many patients will say they're dizzy. And I think we've talked about this before, but it's been a long time and it's one of my favorite topics. And by this time, we don't usually even have volunteers. So I'm gonna go on for a little bit about dizziness until people start giving me the emojis that say, stop, we only have one word. But I think this is important. It's a very common chief concern to understand how to approach this. So, and many of the things that both Ravi and Pramis said are I'm gonna sort of put them in sort of some buckets here that I think will help think about this. So first, if a patient says they're dizzy, the classic teaching, which comes from a paper by, I think, Drachman and Hart, I forget the second author, in probably the 70s, they reviewed a bunch of patients who came to their clinic with dizziness and said, really, dizziness is one of four things. Now, spoiler alert, this is actually helpful, but going to be debunked, but it's worth going through anyway. And those four categories of dizziness are: one, vertigo, meaning a true sense of motion. And if the patient is really saying the room is spinning, that this would correlate with some type of problem along the vestibular pathway, which Pramis and Ravi told us together is from the inner ear through cranial nerve 8 to the brainstem and cerebellum. So if the patient really says room spinning, it's some problem along that pathway. And then type 2, I forget if I'm doing them in order, but I think so, is lightheadedness. Not true room spinning, but lightheadedness. And that's the sensation that would make us think diagnostically of something more cardiovascular, like orthostatic hypotension, or the patient is on a new antihypertensive or something like that. And then type 3, they describe as imbalance, where the patient says dizzy, but what they really mean is they're unsteady on their feet. And one of my mentors, Dr. Marty Samuels, used to teach us and taught me, so I won't say used to, but I remember him saying in clinic, are you dizzy in your head or are you dizzy in your feet? In other words, is the sensation something in your head that you're off balance, or is it your feet that don't feel right on the ground? And then that has a very, and balance meaning that dizzy in your feet, quote unquote, right? And so what is dizziness in your feet? That could be orthopedic or proprioceptive or something related to pain or something related to some other type of higher order gait problem. We've spent hours in this morning report and other times talking about gait, so I won't go there, but it's something with gait, which obviously has a broad differential from orthopedic to neuropathic to myelopathic, et cetera. And then type 4 dizziness, they describe as sort of being non-specific and maybe the kind of just sort of vague sensation that something's not right or doesn't feel right, which could be from medications or could be from anxiety, but not a neurologic, cardiac, or gait disorder. Now, this is a useful framework to ask patients, is the room spinning? Are you dizzy in your head and your feet? And those sorts of things. However, David Newman-Toker at Johns Hopkins has really devoted his life to figuring out how to make an appropriate diagnosis in patients who are dizzy, because this is really common and the stakes are actually quite high, because based on the things Pramis and Ravi told us, right? A patient could have BPPV, benign paroxysmal positional vertigo, very benign condition we can take care of in the office by just moving the patient's head through a few conditions. Or the patient could be having a cerebellar stroke, which is life-threatening, and both of those could present with dizziness. And Newman-Toker debunked this classical teaching that if the patient says room spinning or not, it helps. I did a very clever study, probably early 2000s or so, where they went and they had patients, asked patients, is the room, who were in the emergency room for dizziness, they asked them, is the room spinning? But they also had them fill out a survey, and then someone came back later and asked them, is the room spinning? And they found that patients had no consistency as to whether, even within the same patient, they described their sensation as spinning or not. And that whether they said spinning or not didn't even correlate with whether they were having a cardiac arrhythmia or whether they were having a cerebellar stroke or whether they were having an inner ear problem. And that's not meant as a critique of the patient, right? These things are hard to describe and people use different words for the same thing. And if you keep asking the patient, is the room spinning? They might tell you, okay, doctor, it's spinning, right? You sort of have led the witness a little bit. So he sort of says, we don't need to, actually the title of his PhD thesis on this topic is what do you mean by dizzy shouldn't be the first question we ask to a patient with dizziness. Now, I don't totally agree with that. It's still helpful to go through the history for those 4 parts I mentioned, but what he argues in this paper, yeah, thank you, Maria, my room is spinning right now. What he argues in this paper is that patients are much more consistent on reporting the timing of their dizziness and the triggers of their dizziness. And if you use those 2 factors in the history, timing and trigger, those actually correlate much better with the underlying pathophysiology. So what timing and what triggers? So the big flow chart here is first, is this acute onset vertigo? Meaning the patient has suddenly become dizzy and is still dizzy when you see them. That's one bucket. And the other bucket is this chronic vertigo. And acute onset vertigo, the so-called acute vestibular syndrome, is a very short differential diagnosis, but a high stakes one. And the differential is between vestibular neuritis, which is a benign viral or post-viral condition of the inner ear, and between brainstem cerebellum and brainstem or cerebellar stroke. So do you have a benign 8th nerve problem or a life-threatening stroke? The patient only symptom might be vertigo. We'll talk a lot more about that when we hear whether this is acute or chronic. I won't go down that deep rabbit hole, which will get us into nystagmus and all sorts of other things. So vestibular neuritis versus stroke or intoxication of some sort can also do this. And then if the dizziness is chronic, meaning the patient comes to the clinic and said, I've had dizziness for months, here's where we get into triggers, right? So the next question to ask is this vertigo episodic or continuous? And if it's continuous, that has its own differential diagnosis, which we'll get into. And if it's episodic, the next question is it provoked or unprovoked? In other words, is it triggered or spontaneous? And if it's provoked, what is it provoked by? By head turning as in BPPV, by standing as in orthostasis, et cetera, et cetera. So the sort of flow chart here is acute versus chronic. And if it's chronic, is it episodic or continuous? And if it's episodic, is it provoked or unprovoked? And if it's provoked, what is a provoking factor? I think my very first tutorial that they didn't know, but I was trying to get Robbie and Ray's attention and say, I want to come do things with you all. Hey, look, here's what I will say about dizziness, and tag them and see if they like me. And so I have a tutorial on this that has that flow chart drawn out. It's probably January 2020, a long time ago. And that was, they didn't know, but my little audition attempt to get their attention and say, wow, you guys are cool. I want to come and be part of this. Here's what I do. And the rest is history. So we'll get into what those buckets mean as we hear the history. But so what we'll want to know on this history, right, is the room spinning or not? Although Newman-Toker will strike me with lightning for asking that. And what are the features of this? Did this come on suddenly and stay? Is it chronic? If it's chronic, is it continuous or episodic? If it's episodic, does the patient notice something that brings it on or doesn't bring it on? This is a really helpful framework, because we'll see that as we get further down this flowchart, each differential diagnosis, each bucket sort of has 1 or 2, at most 3 things in the differential diagnosis. So I always like to draw out the chief concern right in the framework for this purpose, so that we have a sense of now, as we hear the history, where we're sort of going down this schema. Okay, thank you for that word, Gabby. So I'm sure you asked many of these questions on the history. Tell us what you learned on the HPI, and then we'll see where we are in this schema.
Yeah, of course. I just sent on the chat the link for your tutorial.
No, thank you.
So if someone wants to check it. So back to the HPI, it's a 50-year-old female that presents to the clinic with vertigo. She described it as a spinning sensation. She had associated nausea, vomiting, and difficulty walking that started suddenly while she was walking one day before. After the onset of the symptoms, they were persistent by the time she came to the clinic. She denies any other associated symptoms. The vertigo gets worse when she moves her head, and she has a previous history of feeling sick 2 weeks before the symptoms. She had cough, sneezing, fatigue. She actually did 3 COVID tests that were negative, and the symptoms resolved after 4 to 5 days. She denies ethanol or tobacco use, and she has migraine without aura, 1 to 2 episodes per week previously. That's it for now. Social history and all of the rest is normal, no allergies and no health-related behaviors.
Excellent. Thanks, Gabby. Okay, I think you were first last time, promise. So Ravi, what do you make of this history?
Yeah, the history, so 50-year-old female, so middle-aged female, and so it's acute since 1 day. So to me, the time course is acute and it's persistent. Vertigo worse with head movement. In addition, sick 2 weeks before. So what it tells me that she probably had upper respiratory infection preceding this sensation of dizziness. So this viral syndrome may get accompanied with this vertigo. To me, it's suggesting peripheral characteristics compared to central. So I'm thinking of vestibular neuritis because of the viral syndrome. Thank you.
Great, Ravi. Let me ask you a few questions because you said some important things there. First, you said you wanted to classify this as peripheral versus central. Can you tell us what is peripheral in the vestibular system and what is central?
That's a good question. Peripheral system includes the ear and the central would be brainstem, and that's all I know. Sorry.
Yeah, no, very good. The peripheral part is the ear, and then are the cranial nerves peripheral or central? I was confused on this for a long time and find many people are not sure the answer to that. Is cranial nerve 8 part of the peripheral nervous system or central nervous system?
I would say both.
Peripheral. Both. You would suspect I'm asking a trick question. I'm actually not asking too much of a trick question, although everything in neurology can feel a little bit tricky. The cranial nerves are, what is it?
Central?
Yeah, the cranial nerves are actually peripheral. And that's important to know because it's very important. It's very common to have cranial neuropathies in Guillain, one of our French-Canadian participants told us is the correct pronunciation. I still can't do it. Guillain-Barré syndrome, except cranial nerve 2, the optic nerve, because the eye itself is really part of the central nervous system from development. If you remember from embryology, the eye kind of grows out of the brain. So that's why in multiple sclerosis, you get optic neuritis, but none of the other cranial nerves are affected. So the peripheral part of this system is the inner ear, utricle, saccule, semicircular canals, etc., and the vestibular portion of cranial nerve 8. And then the central part is the brainstem and cerebellum. So those are the central vestibular pathways are in the brainstem or cerebellum. So that's going to be important. And one of the main questions we're going to need to sort out here is whether this is peripheral or central. And you said you thought this was peripheral. What made you say that, Ravi?
Yeah, what made me say peripheral because she doesn't have any weakness, no motor defects, sensory defects, However, she does have gait dysfunction. She doesn't have nystagmus.
Yeah, we don't know yet, right? Patients with nystagmus often don't notice it, don't tell you my eyes are jumping. They can have some oscillopsia, but usually they don't notice it. The brain must be somehow tuning it out. So we don't know that for sure. But yeah, well, this is where this gets really tricky, because peripheral and central vertigo, peripheral and central causes of vertigo can present very similarly, just with vertigo, nausea, vomiting, and difficulty walking. And this is where Newman Toker saw, as a busy resident in the Mass General Hospital emergency room, as a resident, seeing countless dizzy patients and seeing that there's actually a very high risk for misdiagnosis. Because as Ravi said, if the patient had dizziness, vertigo, difficulty walking, and some obvious focal deficit, ataxia or diplopia or something like that, it'd be pretty easy to say this is central, right? But if the patient has just vertigo, they can still have a stroke, and the other features can be very subtle. And so Newman Toker developed this very clever set of bedside tests that are extremely sensitive and specific for teasing apart vestibular neuritis and posterior circulation stroke, which we'll talk about in a moment. But you might say, well, either way, let's just get an MRI to be safe. Turns out the strokes that we might be looking for here that can cause vertigo can be very small, and they're in the posterior fossa, and there's a certain false negative rate for MRI in that context. And a recent study, probably in the last few years, I remember I was in Boston when I was reading it, so at least 3 or 4 years ago. Ed Lowe is one of the senior authors, or one of the main authors, showed that was a systematic review that MRI misses acute, so the DWI sequence of MRI, which we consider to be sort of the gold standard for seeing ischemia, is only 87 or something, 90% sensitive, which is scary to think you could miss 1 in 10 strokes, or maybe it's a little less than that. But the most commonly missed ones, in other words, they did an MRI in a patient they thought was having a stroke, they didn't see any, and they repeated the MRI 72 hours later, or the clinician said, this is 100% a stroke, there's nothing else. It could be the MRI is wrong. That was more common in the posterior fossa. So one of my mentors used to call this very syndrome that Gabby is presenting to us fatal gastroenteritis, because the patients would come, or could turn out to be fatal gastroenteritis, meaning what? The patient comes to the emergency room, dizzy, nauseous, vomiting. They say they can't walk, but they look weak from nausea, vomiting. No one does a very close exam. Then they go home and die. What was it? Well, someone thought it was gastroenteritis, but it was a big cerebellar stroke, and they herniated. So that is fortunately uncommon, but to show you that the stakes are high here. So in our flow chart, right, we said this is this acute or chronic? And Ravi identified for us, this is acute. This is the acute vestibular syndrome, sudden onset vertigo that's persistent. As I said, the differential diagnosis there is pretty small. This is really between vestibular neuritis and posterior circulation stroke. And how do we distinguish between them? Seamus 10 steps ahead of us. Don't look at that teaching. Promise, do you know a little bit about how we might distinguish these on the physical exam? I should also say head trauma and intoxication are in the differential, but those are usually clear. But we have this acute onset vestibular syndrome, nothing obvious on the exam, the eyes pointing in 2 different directions, the patient's obviously ataxic. How would we tease apart the peripheral syndrome of vestibular neuritis, 8th nerve problem, versus a central problem in the brainstem or cerebellum, namely a stroke?
Yeah, so I think Ravi also mentioned some of that. Like if it was a stroke, seeing you would also kind of have like weakness or other problems. And I think mainly the pertinent negatives that I would think about is this patient hypertensive? Do they have those risk factors for stroke? And then, let's see.
Yeah. Oh, hello?
Yeah, I'm here.
Oh,
I'm kind of processing this.
Oh, sure.
Yeah, I lost my
like we can't tell with your mask if you were talking or not, and it sounded like you stopped in the middle of a sentence. Sorry, go ahead. Take your time.
Yeah, but yeah, mainly I think like thinking about the pertinent negative for stroke in here important to help rule out stroke. And then I thought it was interesting because this patient has some gait problems. So when I heard about that, I was thinking a lot about maybe a cerebellar lesion, which you could have for vertigo, nausea, vomiting, and then depending on how that gait is, if it would be maybe a midline lesion or a lateral lesion. I don't know too much about vestibular neuritis. We didn't learn about that, so I think that's kind of where I'm at right now.
Great. You just said something very nuanced, which I just want to highlight, which is that the gait problem could be either a midline cerebellar problem or a lateral hemisphere cerebellar problem. What did you mean by that? Because I know what you mean, but I want to make sure other people understand what you're referring to there.
Yeah, so the midline of the cerebellum kind of takes care of more of like the body. So then you would see like a truncal ataxia, and then usually you would see like eye movement abnormality, which this patient doesn't have. Whereas if it was like the lateral side, then it more affects the extremities, where you would see like a limp ataxia, and also kind of like movement problems and like weakness and tremors, so which this patient doesn't have either.
Yeah, excellent. So we don't know yet, right? But until we see the exam, what that difficulty walking is, but that's excellent promise. So the midline cerebellum, the vermis, is more concerned with the middle of the body. So that's easy to remember. And that means sort of the trunk. And so midline cerebellar lesions tend to affect the gait and truncal stability. And hemispheric lesions, the lateral part of the cerebellum, tend to affect the limbs. Now, if you have severe limb ataxia of one leg, then of course you're also going to have gait ataxia. But you can distinguish those on the exam, right? With the heel shin testing, presumably in a midline cerebellar, with a midline cerebellar lesion, there would be normal heel shin, but very impaired gait. And a lateral lesion, there would be impaired gait, but you would be able to explain it with deficits on heel shin testing, right? And then you asked the question of how would we really distinguish if this is peripheral or central based on eye movement abnormalities, and I think that may be the crux of why Gabby brought us this case today. And this was the big innovation of Dr. Newman-Toker. So I encourage everyone to take a look at this paper from 2009. The first author is, I'm blanking on the name, but he's the last author, and he describes something called HINTS testing, where HINTS stands for head impulse, nystagmus, and test of skew. And what this paper showed is that with those three bedside tests, and we'll talk about them in the course of the physical exam, or maybe before, depending on looking at the time, those three tests together are actually more sensitive and more specific for distinguishing vestibular neuritis from stroke than MRI. It's an amazing paper, right? To think that things we can do at the bedside are actually more sensitive than this incredibly sensitive test. And there's a nice table in there that shows, to the point that Promise and Ravi were making, well, if the patient has ataxia, well, hey, that's really sensitive for central, right? That's easy. If the patient has obvious eye movement abnormalities, if the patient has anything on the neurologic exam, aside from vertigo, that is obvious for central. But the specificity is actually quite high, but the sensitivity is actually pretty mediocre in sort of the 60 to 70% range. And this HINTS testing, which are very nuanced vestibular tests, which we'll talk about, are actually more sensitive than distinguishing peripheral from central causes of vertigo in this acute setting. So what is HINTS testing? I think it's probably worth going through this. I know we've done it before, but we have time, and this will help us understand the exam. Actually, do you want to explain it, Gabby, or you want me to explain it?
Sorry, to explain the Hinge exam?
Yeah.
That
You don't have
okay,
to put you on the spot, but you're welcome to, or I can do it, or we can tag team.
I can explain it. so for the head impulse, you're going to test the vestibular function. You have to take the head of the patient and move it fast, the head to the right and to the left. The normal response is the response that like we have. So our eye is going to fixate in the examiner's eye. So you're going to do like this, and this is the normal response. If you have a peripheral lesion, the vestibular lesion from one side is not going to connect the eye stimulus with the brain stimulus, and the person is going to do like kind of a bit to correct the eye when you move the head to one side, to the affected side. So if the head impulse is not normal, then it indicates a peripheral lesion. For the N, it's the nystagmus, and then you're going to look for central and peripheral characteristics of the nystagmus. So central characteristics are vertical nystagmus, spontaneous nystagmus, nystagmus that change their phases when you move the eyes of the patient. And I think these are the main ones, probably. And then for the test of skill, you're going to, you can do it by two ways. You can first, so you're gonna check if the eyes are misaligned. So you can first ask the patient to look at your nose, and then you put the lights on the eyes of the patient, and if the reflex is normal in both sides, if the pupil has the light in a horizontal line, then there is no skew deviation. And the other thing you can do is to do the cover and uncover test, where you ask the person to look at you and then ask the person to cover one eye and then remove, and the eye is going to do a little movement for indicating that there is another a possible other brainstem lesion, another cranial nerve lesion. I think the more difficult part is to understand that the normal hand impulse is actually indicates a peripheral lesion, and you can remember that by thinking that it tests the peripheral nervous system. I think that's it. Sorry, I was nervous. Right. I don't know if I was clear.
No, brilliant. No one can tell you're nervous, and I didn't mean to put you on the spot, but I know you brought this case and wanted to give you the chance to explain it. So that's brilliant, and I also wanted you to do that so we can do something we don't usually have time to do, but everyone had, we got volunteers early, and that's to hear two neurologists explain something in two different ways, so you can understand it in whatever way makes sense to you, or the sum will be greater than the parts, because that was a brilliant explanation by Gabby. So there's three tests here. One is the head impulse test, which Gabby explained beautifully. You ask the patient to look at your nose, and then you turn their head side to side, and you're testing something called the vestibulo-ocular reflex, which we have time to explain, and I'll explain in a moment. And if it's normal, the eye should move in the opposite direction of the head instantly. And that's called the vestibulo-ocular reflex. So that if you're, drive in a bus and trying to read, the book isn't doing this, right? Because your eyes are moving in the opposite direction of your head. And you can inhibit that, right? If you want to take a picture of a bird and it's flying, and then you take the picture, right? You don't want your eyes to be dragging the other way. So we can inhibit the VOR. And then nystagmus is a whole complicated discussion, but we'll tell you what you need to know for this particular instance. And then test of skew, as Gabby said, skew deviation is a vertical misalignment of the eyes. If you see it, well, that's easy. But as Gabby said, it can be subtle sometimes. So you can cover the patient's eyes and go back and forth and see if you see the eyes doing this little vertical adjustment. That would be a skew deviation. Now, how to actually distinguish peripheral from a central, Gabby did a great job explaining this. It's very hard to understand, and I tried many times over and over again until I understood it. So here's how I teach this. I hope this is helpful. So how does the vestibulo-ocular reflex work? If you understand this, the other tests will make sense. sort of. So here's how this works, right? You have the inner ear, and the inner ear is communicating through the eighth nerve to the brain stem, right? And to make sure that the vestibular apparatus, right, has fluid in it, so that when you move your head, that fluid has a change in its momentum, and that is signaled through electrochemical signals, right, to the eighth nerve, so the brain knows which direction the head is turning into. So how does this work, right? Here's how I imagine this. Both eighth nerves are tonically active. So my fingers are the activity in the eighth nerves. They're tonically active. And so when I turn my head to the right, this one gets more active. The fluid shift tells the nerve to be more active. So what the brainstem sees is, hey, the right vestibular nerve is more active than the left vestibular nerve. The head must have turned to the right. So the eighth nerve through the vestibular nuclei, through the MLF to cranial nerves 3, 4, and 6 says, hey, the head's turning to the right, turn the eyes to the left. Similarly, if I turn my head to the left cranial nerve 8 gets real excited. The brainstem sees, hey, left is greater than right, so I better turn my eyes to the right side. So that's the normal vestibulo-ocular reflex. You might have learned about cold calorics, right? In the coma exam, the brain death exam, same idea. You pour cold water in the left side, what does the brainstem see? Well, hey, this side's not doing anything. There's tonic activity here. The brainstem says, oh, well, right is greater than left. I guess the head is turning to the right. The eye should go towards that left. So the eyes go towards the cold side. So if you understand that, you can understand the hints testing. How can we understand it? So as I said, normal, 1/8 nerve gets more excited. Brainstem sees one side greater than the other side and sends the eyes to that opposite side. So let's first talk about the head impulse test, right? So if the eighth nerve works on both sides, you turn your head to one side, the eighth nerve says, hey, you turn to my side, send the eyes to the opposite side, no problem. But if there's a vestibulopathy on one side and you turn the patient's head to that side, the vestibular nerve didn't register the signal and send it to the brainstem, right? Because there's a vestibulopathy on that side. And the brain knows, hey, I was supposed to look at the nose, but the eyes first go with the head, and then there's a quick catch-up saccade. That's an abnormal head impulse test because the eighth nerve or the vestibular apparatus isn't working on one side. So when you turn the head, there is no VOR. There's just the brain saying, hey, I was supposed to look at the person's nose. And the eyes catch up. That's called a catch-up saccade. And as Gabby said, the key challenge here is that the abnormal test in this context, the context of acute vestibular syndrome, an abnormal sign is actually reassuring, right? Because it tells us, oh, we have a vestibular neuropathy. And in this case, it's probably vestibular neuritis. And the normal sign, meaning the apparatus works on both sides in the setting of acute vertigo, is the worrisome sign. As Gabby said, this is hard to remember. The normal sign is the one that would scare you in this context because it tells you that that eighth nerve to 6, 4, 3 through the MLF is all working and you have something else going on in the cerebellum or brainstem. So abnormal head impulse test in this context, reassuring. Normal head impulse test in this context is frightening, that you could be seeing a stroke. So that's the head impulse test. What about nystagmus? Now we could do a whole session, hours and hours on nystagmus. It's very complicated, but nystagmus 101 here is this. In a peripheral vestibulopathy, again, so imagine normally both eighth nerves are tonically active, okay? Now imagine there's a vestibular neuritis on the right side. I don't know if my camera is flipped, but this is my right side, right? So what does the brainstem see? It sees that the left cranial nerve 8 is active and the right is inactive. So it thinks the head is turning to the left and it should turn the eyes to the right. But the brain is saying, no, I don't want to turn my eyes to the right. I don't want to turn my eyes to the right. I don't want to turn my eyes to the right. I don't want to turn my eyes to the right. And so you get nystagmus with the slow phase towards the abnormal side and the fast phase towards the normal side. No matter what direction you turn, there's an asymmetry here. So the nystagmus is always beating in the same direction. That is called direction constant nystagmus, meaning the nystagmus is always, whether the patient looks left, looks right, is always beating in one direction because there's a vestibular asymmetry. And there's something, blanking on the name for it, so Alexander's law. So imagine that we're in this situation, right? The right vestibular nerve is out and the patient looks all the way to the right. Well, that's where the eyes thought they were supposed to be. So the nystagmus will calm down. And if they look all the way to the left, oh, they really wanted to go to the right. And so the nystagmus intensifies. That's called Alexander's law. That would be a peripheral pattern of nystagmus. And what happens centrally? Well, centrally, there's two types of neurons involved in eccentric gaze, looking to one side. One is the burst neurons that send the eyes over in the saccade, and then one is the pause neurons or the step neurons that keep the eyes there. If you look all the way to the left or all the way to the right, you can sort of feel that it takes some neural effort to really keep your eyes over there. And in central vertigo, the gaze holding is impaired. So when gaze holding is impaired, you try to look all the way to the left, you get left beating nystagmus. You try to look all the way to the right, you get right beating nystagmus. That's called direction changing nystagmus. And that direction changing nystagmus would worry you for a central lesion. So asymmetric direction constant nystagmus, peripheral direction changing nystagmus, central. And then the skew, if it's there, it's usually central. Rarely you can get a peripheral cause of skew. That requires a level of vestibular neuroanatomy understanding that I do not have, and has something to do with our evolution from when we used to be fish and the eyes were on the two sides of the head and the head turns in relation. It's super confusing. Only Sashank Prasad can explain that. I've heard it many times and applauded, but don't entirely understand it. So hints, if we see a normal head impulse test, direction changing nystagmus, or positive test of skew, not and, but or, any of those should worry you for stroke. And Newman Toker really wanted people to remember this. He didn't give us just the hints mnemonic. He gave us the mnemonic infarct, which is impulse, negative, fast, phase of nystagmus, alternating, refixation on cover test. Not the greatest mnemonic because there's lots of extra words there. But head impulse, impulse normal, fast phase of nystagmus, alternating, refixation on cover test. Okay, so now we know exactly what we're looking for on this physical exam, right? Are there any obvious focal findings to tell us we're central? If there's nothing obvious, then we need to do this detailed hints testing. And if we see a normal hints test, direction changing nystagmus, or positive test of skew, we're worried about a stroke. If we see an abnormal head impulse test to one side, direction constant nystagmus, and no test of skew, though you can see it in peripheral, we'd be thinking more about peripheral causes here. So I hope that's helpful. This is really complicated topic. I had to go through it a million times. That's how I like to explain it. I'm so glad we got to hear how Gabby likes to explain it. And someday you'll have your way of explaining this too. So what did you find on the exam, Gabby?
Yeah, awesome. It's always good to hear your explanation.
Oh, thank you. Yours too.
About the neuro exam, the mental status was normal. Motor, reflexes, sensory and cerebellar were normal. I'm going to say the Hinge exam now. The head impulse, the patient was unable to maintain visual fixation when I turned the head to the left. So it was a positive test. She had horizontal torsional nystagmus that was suppressed with visual fixation. And the fast phase was beating to the right. She had gait instability. She was actually able to walk, but she reported some instability. She didn't have any gait pattern like ataxic gait or hemiplegic gait or something like that, but she was unstable. What else? Test of skill was negative. And I also performed the Rini and Weber tests. They were also normal. That's it for the exam. And vitals were normal as well.
Okay, so we have a normal exam except the Hinge testing. And let's make sure we understand what we saw here. So patient is unable to maintain visual fixation. Did you say specifically on the Hinge testing, or in general, when they're looking straight ahead, you saw some nystagmus?
No, only on the head impulse test.
I see. And do you remember to which side the head impulse test was?
When I turned the head to the left. Yeah.
So turn your head to the left. Got it. Okay, so abnormal head impulse test to the left. And then you saw horizontal torsional nystagmus with the fast phase to the right. That could be suppressible, meaning overcome by fixation. And then skew was negative and the gait was unstable. Excellent. Well, not to put Ravi and Pramis on the spot, since Hinge testing might be relatively new to some folks, that I didn't learn about this till I was a resident. Well, I should say Newman Toker was my attending when I was a medical student, and he talked a lot about this. And I thought, why is this guy so obsessed with dizziness? And then when I was a resident, I learned why and read his paper and saw actually what an amazing contribution he had made. So, but if you've just heard about this for the first time, no worries. Ravi, Pramis, how would you interpret this, this Hinge testing? You can take one piece of it or multiple pieces or whatever you feel comfortable with.
So I can start, and then Ravi, maybe you can fill in my gaps. So from what I just learned, since this patient has a negative test of skew, so that brings us away from the stroke, but then she's showing a fast phase to the right, so that is more of a central nystagmus. So I don't know how you interpret if you have like one positive, but like one that's abnormal and then one that's like a good one to have. Let's see. And then I thought it's interesting with the localization that she has a head impulse that is on the left side, and then but then her nystagmus is, wait, no, let's see if that's turning to the right, so that's the right eye, or okay, I think my brain is a little confused with the location, so maybe you can help me out with that.
I think I'm remembering, I haven't looked again at it, but the tutorial Gabby posted, I think I began with the question, does dizziness make you feel dizzy? And doesn't it make us feel dizzy to try to work through this? You did a great job, Pramis, trying to parse apart these three tests, right? Test of skew being normal is reassuring. And then the head impulse test here is abnormal on one side. Is that reassuring or concerning?
You said the skew test?
Oh, the skew test you correctly interpreted. It's normal, which is reassuring, right? Makes us think peripheral. How about the head impulse test being abnormal? Is that reassuring or concerning? And when I say reassuring, I mean
that's reassuring.
That's reassuring, yeah. And then the nystagmus being unidirectional, is that reassuring or concerning?
You said that bidirectional is central, right?
Correct.
Okay, so then that's reassuring. Okay, so then that would put us into a peripheral.
Good for you. This is a very confusing topic, and you got it right off the bat. So right, let's try to tease this apart since we have time. And so off the bat, the head impulse test is abnormal. And this is already confusing, right? Because the normal test is the one where we worry less. But let's analyze this a little bit. So Gabby found when she turned the patient's head to the left that the head impulse didn't work. Now I have to mention to you, when you do the head impulse test, you really got to look closely because the brain will learn, right? And so if you do this a few times and you're not sure and you keep doing it, you'll lose sort of the ability to understand the test because the patient will habituate. So there's definitely times where the resident says, I swear it was abnormal on this side. They do it a few times, the attending comes, and then you say, it looks normal to me. And they say, I promise it was before. Or I do it and I say, I think that was, let me just do it again. And the other thing Newman Toker taught us is, don't just go left, right, because the patient will learn quickly what you're doing. And so he said, be like the good boxer and surprise them. Right, left, right, left, right, left, like the boxer sort of confusing their opponent. And the other trick he told us is a lot of people go from center to the side, and it's actually very hard to see what happens when the eye gets to the lateral canthus. To actually start all the way on the side and see what happens trying to get the head back to the middle. You have to really remember that going back to the middle, did you go left or go right? And I always have to ask myself before I do it, okay, I put the head all the way to the right. By going to the center, I'm sending it to the left. What do I see? And then you can get a sense of whether the eyes miss the center line or not. So I thought it was a very interesting pearl from him. So what did we see here? We saw it abnormal on the left side, meaning there's a left vestibulopathy, right? When Gabby turned the patient's head to the left, or she had it all the way to the right and turned it to the left. The eyes missed the target and then had a catch up. So is that consistent with nystagmus? That's right beating in all directions. Well, let's go back to our eighth nerves here. And if the left side is out, Ravi or Promise, if the left side is out and the right side has its tonic activity, where does the brain think the head is turning? To the left or to the right?
Brain probably thinks to the right.
Exactly, right? Because it's seeing 1 is greater than 0, this tonic activity, and the brain doesn't know it's because there's disease on this side. It just thinks, oh, the head must be turning towards the right. So where does it want to send the eyes if the head is going towards the right?
Left.
Wants to send them left, but the brain knows it's not supposed to go there, so it keeps trying to send them back, right? So we have slow phase to the left, fast phase to the right, and Gabby told us it's suppressible with fixation, tells us that central nervous system can overcome it. And so all of those line up with a left vestibulopathy. So are we finished here? Do we know the diagnosis? Promise or Ravi?
We can do the hearing test, the Weber, and to see the lateralization.
Yeah, so if the hearing is out,
Hearing out.
that is a little bit tricky. There's another paper by Newman-Toker called Hints Plus that he said if hearing is out, also it suggests a infarct of the labyrinthine or internal auditory artery, which is a branch of the anterior inferior cerebellar artery, and you can actually infarct the labyrinth. So you would think, oh, with hearing losses there, that must really suggest something peripheral, but actually it is concerning for central. I've never seen that in real life, but something he's described also. But Gabby has told us the hearing's normal here, so that keeps us strictly in the vestibular pathway. So if all the signs are pointing to peripheral, are we finished? Do we know the diagnosis? Do we need an MRI? What do you both think?
I'm gonna take a guess. Since you said that this test is like actually very sensitive, and then just given this patient's history, I think that these findings are better than an MRI or a CT scan. But I don't know if in the hospital, like in clinical practice, like it would be important to do one just for the purpose of like ruling out.
Yeah, great question. And this is the Achilles heel of Hints testing. Newman-Toker came up with something amazing, but many times as a neurologist, I'm called to the emergency room. They said, we did the Hints testing, but it wasn't clear, and we did an MRI. And Gabby's nodding also. Or you go and you do the Hints testing and you say, I'm pretty sure that impulse test was abnormal on the one side, but it wasn't entirely sure. And if you look, he's not 100% sensitive, because if you infarct just the vestibular nuclei on one side, you can actually look peripheral because you've gotten the sort of peripheral central junction there. So in principle, this exam is 100% consistent with peripheral, right? Which in this context suggests vestibular neuritis. The patient had a cold a few weeks ago. If you're feeling confident, you could say, based on this, I'm not going to get an MRI. You're right, Promise, that in most settings, a patient comes to the emergency room, people's reaction, I think, to Hints testing was, wow, we're missing stroke a lot. We better be doing more MRIs, where I think Newman-Toker wanted the teaching to be selecting the right patient for an MRI. But, you know, in the Hints study, it was neuro-ophthalmologists and neuro-otologists doing the bedside exam. That's not the resource most people have available. So if there's any ambiguity and the resource is available, it's reasonable to get an MRI. And I've seen lots of patients admitted for stroke, waiting for their MRI. And by the time we see them on rounds and we say this is peripheral, usually within about 24 or 48 hours, they're 70, 80% of the way better, which is not the case with a stroke. But the stakes are high, and if it's ambiguous at all, it's certainly worth the MRI. But if the resource is limited and you had to make a call who gets it and who doesn't, this seems like a good candidate to defer it. And so if this is peripheral and it's acute and the patient had a cold, Ravi said the diagnosis earlier, this is probably vestibular neuritis. We don't really know what causes that, presumably viral or post-viral. I think of it almost like a Bell's palsy of the eighth nerve. It's either viral or post-viral. We don't know. We usually treat with steroids, so there's not great data as there are for Bell's palsy, and usually the patients get better. So Gabby, tell us if you were feeling bold enough not to get an MRI, or what happened next?
Yeah, that's funny that you mentioned that, because what happened is that I actually ordered an MRI for her because she had an asymmetric smile. We didn't know if this was new or previous, and I just ordered the image, but the brain MRI was normal. So the final diagnosis was vestibular neuritis. Yeah, and despite the low data on corticosteroids, everybody treats with corticosteroids, so I treated her with prednisone, and after the 7 days, she was already better. And also I gave her some medications for nausea and vomiting. And most of the patients have only this once in their lives, so it's something good to reassure the patients, because they usually feel very sick. And it's very scary.
Yeah, this is the scary thing. If you look at this patient and a patient having a cerebellar stroke, they look very similar. They look extremely sick. They're throwing up anytime they open their eyes, anytime they move their head. They can't walk because they're so dizzy. And one of them is benign and will get better in a few days to weeks, and one is life-threatening. So that was the great innovation of Newman Toker to tell us how to sort this out at the bedside. Because if you can't even rely on MRI to give you the diagnosis, for a neurologist, that can be frightening, right? And Gabby, tell me your experience, but my experience with these folks is that when you admit them to the hospital, either because they're so sick or because somebody thought they were having a stroke, usually within a day or two, they're 70, 80% better. And then over a few weeks, they become fully better. Is that your experience also, that the acute phase is usually pretty self-limited? There's a little bit of a tail where they feel like anytime they sort of turn their head to parallel park their car, there's a little bit of dizziness because that vestibular apparatus is not fully recovered. Is that your experience also for the time window, how it evolves?
Yeah, that's what I have in mind and what I've seen in the few patients that I saw with vestibular neuritis. It's very fast.
Yeah, two other important clinical points here. One is a lot of patients will be given meclizine for this. That's fine for a few days. Patients should not be on meclizine as a chronic medicine. I see this so commonly. Meclizine actually inhibits central compensation for vestibular asymmetry. And the central compensation is the healing, right? The vestibular nerve gets most of the way better, but if it's still a little off, the brain will figure out, okay, I need to kind of recalibrate my compass here, right? And I've seen patients who are on meclizine TID for months, years, with a quote diagnosis in their chart of vertigo and the treatment meclizine. That's not how this works. This is for a brief episode of dizziness for a short period. And the other little clinical thing I'll mention that I've seen, maybe you've seen this too, Gabby, is I'll see a patient who will come in and say, every time I turn my head, I'm dizzy. And I'll think, oh, they have BPPV. But when you do the head impulse test, you see it's not quite right. And if you take a history, close history, they'll tell you, actually, a few weeks ago, I was really sick. I had a stomach bug or something. Or my kid brought home a cold from school and I was he was sick, but I was okay. And then I felt kind of sick or something. And the history sort of sounds like they got vestibular neuritis and thought it was a stomach bug. And they just have this little residual peripheral vestibulopathy for a few weeks to months. By that point, I don't treat them with steroids, but it gets better. But something to think about in the differential diagnosis of BPPV, where BPPV, the exam should only be abnormal in the Dix-Hallpike position. And these are patients that will also tell you dizziness with head turning, but they'll have evidence of a little bit of a vestibulopathy, unilateral vestibulopathy on exam. I imagine, though I haven't seen this described, that they had an episode of vestibular neuritis. Fantastic. Well, Shema has been busy scribing away. So thank you very much for bringing this wonderful case, Gabby. You know, vertigo is one of my favorite topics. So you're singing my tune today. And Pramas and Ravi, this is seems simple, but seems simple to just say dizziness, but very complicated topic. And you both did an excellent job, both walking through the case. And then when I taught something that was, I think, relatively new to both of you, picking it right up and incorporating it into your decision-making. So that was phenomenal. So let's hear what your teaching points are, Shema.
Oh no, my microphone was out. I'm talking again. So,
Oh,
first, first of all, amazing case, and now coming to the teaching point. So, as we know, the chief complaint of the patient was vertigo, and approaching vertigo, we know the definition is like it's a spinning sensation without actual movement, or generally a symptom of illusionary movement. So it's not a diagnosis. And for a vertigo, consider a time course. Like if it's a very acute form, like if we think of any neurological thing, it can be BPV, Meniere, vestibular neuritis, or any schwannoma, or if we have any cochlear symptoms next to it, it can also be Meniere. And then the key question, is it acute vertigo? Then we have three differentials: vestibular neuritis, a stroke, or intoxication. If it's chronic, consider any consider whether it's episodic, then ask the question whether it's provoked, like due to head movement, or if it's continuous. And also remember the time course localization, is it central or peripheral? And the question in the vestibular system, whether it's peripheral or central, we have discussed the head impulse with the hints, like it's an acronym for head impulse, nystagmus, and a test of skew, because we know where also strokes, like a posterior circulation stroke, that can lead to vertigo. So therefore we perform a CMRI in DVE to exclude it, but it's not 100% sensitive. So we can do on clinical examination some tests, like whereas some hints showing us whether it's central, like if we have a normal head impulse test, this is leading to a central lesion, or if we have a skew deviation on the cover test, or a bidirectional or direction changing nystagmus, this is leading us to central vertigo. And also consider that vertical nystagmus is also rather central than peripheral. And what I also learned and wanted to mention is when we talk about the fixation suppression of the vestibular ocular reflex, which we test on the head impulse test, if the fixation suppression is still working, consider a peripheral lesion, because we know an intact cerebellum is there to yeah, that the VUR is intact, so otherwise it wouldn't work. And also for the dizziness, we were talking about the 4 types. It can be a vertigo, like if when the room is spinning, and it can be any neurological or inner ear dysfunction. And then we have lightheadedness, thinking more of a cardiovascular problem like orthostasis. And the third thing is imbalance, like if they feel dizzy on the feet, it can be orthopedic, any proprioceptive disorder, and it can be also any non-specific thing. And now putting the framework for the case, we have, we were thinking of a left side of vestibulopathy. And the clues are, we have a horizontal torsional nystagmus. And as we know, when one vestibular nerve is involved, that means the healthy side has more activation. Therefore, we have more activation on the healthy side. And as we have seen, the rapid phase was to the right. That means the healthy side is the right side and the pathological side is the left side. And the hints were negative, so it was no central problem. We didn't have any cochlear involvement, so we can exclude Meniere. And we had some vestibular symptoms like nausea, vomiting, and it was acute, and we had gait instability and a recent infection, which made vestibular neuritis very probable. No, very, very likely. Yeah, that's it. Thank you very much.
Excellent summary, Shema. Thank you so much. Again, I know this is a complicated topic. It took me many runs through to finally understand it myself, and then many more runs to be able to explain it to someone else. So just practice with it. I like to use my 2 hands to try to figure out what's going on. And then I think Gabby sent out the tutorial where I try to explain this in as few words as Twitter will permit, with this flow chart for the other side of the algorithm, or schema we didn't talk about, which was episodic versus continuous, and then provoked versus unprovoked, which will maybe be a topic for a future VMR. Great. Well, thank you again, Gabby, for bringing us this case so we could have this discussion. And thanks to Kirtan and Shema for scribing and teaching points. And Promise and Ravi, again, wonderful and brilliant discussion with a very complicated chief concern and set of physical examination findings. I hope we have reduced everyone's neurophobia a little bit, but just know that as I began my tutorial on this, dizziness can make us dizzy, but whatever specialty, and you're going to see patients who are dizzy. And so having a clear framework for this will hopefully be helpful for you. Great. And Maria, do you want to make an announcement?
Yeah, just really quick. Everybody should be getting like weekly reminders of a feedback survey. There you get like the link and the IRB information and everything. Just takes 15 minutes and we'd really appreciate to hear back from you. And if you don't get it, please like reach out. I can send it to you.
Thanks so much, Maria. This is really important to us. We have a big survey for many aspects of VMR, but there is a special section just on Neuro VMR. So those of you who are Neuro VMR regulars, to tell us how we're doing here, how we can improve, what you've learned, what you'd like to see will be so helpful to us. So I see in my email the reminder just came up too. Hopefully it came in your email too. We'd love to have you fill it out. Thanks again, everyone. See you next Tuesday.